Okay, 2:20, we're right on schedule. I'm really excited about this next segment and everything that these co-presenters are going to bring to the table this afternoon. And so it is my pleasure to introduce three really wonderful folks for our resource roundabout. And this will be presented by Liz Crish, Amy Eli Huxtable, and Cecil Watry, who is from the Kansas City Black Mental Health Initiative. This session is going to provide brief presentations from three presenters focused on reducing the stigma of seeking help and providing information about mental health resources available in the Kansas City community and beyond. I'd love to give you a little bit of information about each of them, and then I know that they've got a format, and each of them will present, and then of course we'll have time for some questions afterwards, so please put your thoughts and questions in the chat. Liz Crish is a clinical psychiatric pharmacist at the University of Kansas Health System, and she works between both our Marillac and Strawberry Hill campuses. After completing her psychiatric pharmacy residency at Yale New Haven Health in 2018, she moved to Kansas City to continue to pursue her passion for pharmacy and decreasing the stigma surrounding mental health treatment. She enjoys educating students and residents and is a volunteer crisis counselor outside of work. So welcome to you, Liz. Amy Eli Huxtable earned a Bachelor of Arts in Graphic Design and Studio Art in 2011 and a Bachelor of Science in Psychology in 2016. They graduated in 2019 with a Master of Science in Art Therapy Counseling. Amy Eli has 8 years of experience working with children in a variety of educational, recreational, and mental health settings. They currently work as an art therapist at the University of Kansas Health System Marillac campus and recently authored the upcoming textbook, A Graphic Guide to Art Therapy. I think is very cool. I have 4 children of my own. I love children, and so special place in my heart for people who work with children. And we also have with us today Cecil Watry. He's a licensed clinical social worker and founder of the Kansas City Black Mental Health Initiative, whose work has focused on practice and implementation in mental health, education, and social justice. Cecil received his Bachelor of Science in Psychology from Emporia State University with a Master's of Social Work from the University of Missouri in Kansas City. He has a decade of experience in mental and medical health and has worked with all ages to provide consultation, develop roles within outpatient mental health settings. He's implemented strategies, evidence-based practices, and worked within the community to assist families of color on the micro, meso, and macro level. And he's also worked to implement trauma-informed care, equitable and restorative practices, client-centered and solution-focused practices. Within education, Cecil has been active in the Hickman Mills School District as a previous employee, stakeholder, and currently serves as a Board of Education Director. He continues to devote his experience and practice to community organizing, behavioral, and medical health within the Kansas City metro area. Thank you so much for your involvement, Cecil. So Amy, Eli, Cecil, and Liz, we will let you determine who's going first. And I know you've got this all worked out. Really excited to hear what you have to say, and we'll turn it over to you.
I believe we had Cecil going first. Is that correct? Yeah, great.
That's correct.
He's ready.
I'm making sure I'm unmuted. Hello, everyone. My name is Cecil. And kind of what I want to spend my little portion talking about is more or less is Black youth and suicide. I also want to be able to provide some context and resources towards how to more or less approach Black youth when it comes to addressing mental health and suicidality. And what I would like to start off with is just kind of explain the fact that since 1991, suicide rates in Black children have risen 73%. Black children are more likely to die of suicide, or twice as likely to die of suicide than their white counterparts. Usually this is kind of due to the lack of data and research to figure out why, or to even imply the cultural awareness. and already within Black communities, access to quality resources are a big determining factor. Dr. Charlene Hyling Williams states that there are huge gaps in both access to quality mental health and access to cultural responsive mental health and behavioral health services, which tends to be a large issue in the Kansas City metro area. We do have a lot of community resources that are available, but often access to those community resources, not so much as access, but being cultural awareness being implied within those practices tend to still create a gap of accessibility. Based on, I love that Dr. Sullivan went before us because she's actually a good friend of mine. But one of the things that she kind of leads on to, which I hope I'm not resharing, but like 70% to 80%, 70 to 80% don't say that they're suicidal. 60% of those people who are suicidal or even attempt suicide usually have never received treatment. Lethal suicidal persons often hide their risks to begin with, and there are large, tremendous cultural, gender, ethical differences. And I emphasize ethical in the aspect that cultural and ethical there's a term in the Black community for not all skin folk or kinfolk, which literally means that although we may share in the same race, ethnicity may be different. So some of the factors that increase suicide in Black youth are associated feelings stemming from being marginalized, the traditional paradigm aspect of the fear of seeking help, racial discrimination, and even so much as societal pressures of belonging. There's honestly, one of the biggest precipitating factors that I want to emphasize is the constant exposure to violence perpetuated on Black bodies. Bullying through racism, through forms of racism, whether in person or online. All of this placates into the self. So decreasing this means having support, understanding, and also the aspect of being able to assess a person's resiliency, implying the actual aspect of educating for regulation for talking about mental health and normalizing the conversation of mental health, and simply in the aspect of cultural awareness, having to find better understanding with Black youth that are impacted different ways from their white counterparts. One of the reasons why I want to talk about the difference between the two happens to do with the overarching. I think the overarching precipitating factor is burdensomeness when it comes to suicidality. And a good example of how that looks different is where a middle class white female adolescent may feel the burdensomeness of perfection due to classwork, due to the expectations of the home. Where in burdensomeness with a counterpart, Black could also be the burdensomeness of existence within that family dynamic, within society, trying to find your place in society. Dr. Guys of the UMKC School of Medicine talks about the 6 steps of enhanced suicide assessments that involve trust and connection, a dynamic risk assessment. Dr. Sullivan also want to piggyback on to her in the aspect of the assessments that are done in the ER at Children's Mercy are often dynamic to ensure that it's not just addressing the aspect of what has happened or addressing things as they are, but rather conversely making sure that we're identifying risks which could result from the change itself. Significant changes in that in frequency, severity, just of existing resources of loss, and can come from different places or new sources. So The final thought that I kind of want to leave you guys with within my segment is that quote by James Baldwin, which is that, you know, it comes to a great shock around the age of 5, 6, or 7 to discover that the flag in which you pledge allegiance, along with everyone else, has not necessarily pledged allegiance to you. It comes to a great shock to see Gary Cooper killing off Indians, and although you're rooting for Gary Cooper, that the Indian is you. So when I speak of burdensomeness within Black youth in the aspect of not just suicidality, but also addressing mental health, there are traditional paradigms within culture that perpetuate that. And there is also this realization of feeling displaced within your society. That attached along with the reason why these suicide assessments must be dynamic is the same reason why the approach of clinicians or practitioners also must be dynamic in the same aspect. If I was to give the major resource that I would give to practitioners is that when you're talking to Black youth or able to interact with Black youth, whether it's through a suicide assessment or simply in just casual conversation, 2 things. Listen to them and seek a place of, please seek to understand before seeking to be understood, and believe them. Validate their feelings, emotions, and thoughts, and be able to gain rapport with them. The largest thing that I emphasize as anything to any practitioner within this field that is going to come across anyone that has anything to do with mental health or suicidality is to ensure that if you have great rapport, you have greater expectations. In other words, being able to gain that rapport from the person is allowing you to have the expectation of being able to get the information you need to be able to assist that person. High quality in either one and low quality in the other. Great expectation with low expectations creates the enabling factor, which we often see, where we have the parents who will go on by the rope and not have any idea the aspect of just trying to ensure rapport. And then we have those who, on the other end of that, have poor rapport and high expectations, which come off authoritative, or in a hierarchical sense. We see this in school between teachers and students. So with that, I will turn it over to one of my counterparts and allow them to present, as I do not want to take up too much time.
Okay, great, thank you. Can everyone hear me okay? Okay, perfect. My name's Liz. I'm a clinical psychiatric pharmacist at the University of Kansas Health System. And I just wanted to take some time today to share with you my personal struggles with depression, as well as some things that have helped me navigate through and continue to navigate through this illness. Specifically, I'll be talking about some medications. I want to start with a quote by author Elizabeth Wurtzel. She's wrote the memoir Prozac Nation, if any of you are familiar. That's the thing about depression. A human being can survive almost anything as long as she sees the end in sight. But depression is so insidious and it compounds daily, making it impossible to ever see the end. That fog is like a cage without a key. I love this quote. I think it paints a very good picture of depression, especially when it can be so difficult, even impossible to put it into words. Okay. So my battle with depression started in high school, probably even a little before that. But high school is kind of when I remember starting to question my thoughts. I remember being extremely irritable, very moody. I had very black and white thinking. I think I cried almost every day. And I attributed it to the stress of school, wanting to get to a good college, being hormonal, being a teenage girl, friend drama, high school drama, all the above. And I thought I was just being dramatic. And that's the feedback I got from the outside world and those around me, that I was being dramatic, that I would grow out of it or I'd have to grow out of it. So high school was one thing for me, but I really fell apart in college. When I started, I was extremely homesick. I feel like right off the bat, I was very stressed about getting into pharmacy school. I remember crying all the time. My negative thoughts were out of control. At that point, my suicidal ideation became very real. It was unexplainable. I just felt like I couldn't handle anything. Okay, but I functioned the only way I knew how. I put on a happy face. I went to class. I had friends. I went to social activities. You know, I appeared fairly normal. But about a year and a half into college is when I hit my breaking point and I knew I needed help. It was not an option anymore because I knew if I didn't get help, I would not survive. The pain was constant. My suicidal thoughts were out of control and I was thinking very quickly, just struggling in general to really hold on. And it was getting harder and harder for me to fake it every day. My school had a counseling center, so that's where I first went. I got paired with a therapist, and then probably a few weeks after that, also got in with a psychiatrist there. And that's really where my treatment journey started. I wish I could say that's also where my journey ended. That I went there, got hooked up with a therapist, got on a medication, was good, set for the foreseeable future. That's not what happened. That's not how mental illness works. That's not how depression works. But at that point, my desperation for any sort of relief from the suicidal thoughts really outweighed my hesitation to start medication. Because then I knew I had been to therapy. I knew I had coping skills. I knew I had a support system, but that wasn't enough for me personally. So I started an antidepressant, and I'd say within 1 to 2 months, I did feel some benefits. I felt like I could breathe a little more, and it wasn't that I was instantly happy. That's not how the medications work. But I felt like I could just have a better handle on life. For me, unfortunately, that feeling didn't last as long as I would have hoped. I feel like within 4 to 5 months, I was slipping back into my depression. And whatever benefit I had originally gotten from the antidepressant, I just didn't feel that benefit anymore. And I remember being so frustrated and so disheartened that once again, I felt like I was at square one. Okay. Over the next 6 years from that time, I tried close to 10 different medications. And I'd probably say at least 15 different combinations of those medications, different drugs together, different dosages, all for adequate durations of time, really just trying to find some relief. Okay. And at that point, either regimens did not help, or a certain, combination seemed to help for X amount of time, but then it seemed to stop helping. And just a little pharmacotherapy note. Antidepressants are one type of medication, and they're first-line therapy for depression, but then there's some other classes of medications that can be used in combination with antidepressants. And a lot of times when people have treatment-resistant depression, which is what I was diagnosed with at that time, several medications will be used together. So that's kind of what I'm talking about when I say like combination of medications. I was taking several medications at once, just trying to find some relief, essentially. Before I sought help, I was always looking for an excuse. Okay, so when I was in high school, it was, well, I'm just being dramatic, I'll grow out of it. And then when I was in college, before pharmacy school, it was, well, once I get in pharmacy school, I'll be fine. Like I won't need therapy anymore because all my stress is coming from getting into pharmacy school. So logically, once I get there, I'll be fine, right? When I got in, that didn't get better. It probably got worse because it was just going unaddressed for longer and longer. And I learned very quickly that depression is not situational. It is not specific to one environment. Sure, there are environments and situations that are not helpful for depression or can worsen it, but that doesn't mean you have to be in a certain place or a certain time in your life to be depressed. Okay, and it is very easy to get caught up in the thinking that, oh, once I hit this milestone, I'll be fine. It's so easy to do that. But I had to just accept and believe that my depression was not going to go away. Or not going to be managed unless I faced it head on. Okay, and that's what I did. So that being said, the stigma of medications has always been very real for me. I do not take that lightly. And I wanted to just take the next few minutes to talk about some common concerns or reservations that I've heard about medications specifically, or ones that I had. So a common theme I hear from people is that they worry medications will change them. Okay, that they'll lose themselves, or that they'll be numb, not feel anything. Well, I will tell you, for me personally, they never changed me, but they allowed me to be myself. Okay. So before I started on medications, I was in a downward spiral. I could not get out. Like I had previously mentioned, I did not think I would survive. I was sinking fast, and medications allowed just enough light in, just gave me enough room to breathe that other things could come together. Okay, so I felt I could better engage in therapy. I could more appropriately use my coping skills. I could identify and rely on social supports in a better, healthier way. Okay, so medications just help me really manage my depression. And a quote I recently read that seemed really good. It was a comparison, and it said, medications don't catapult you to the finish line, but rather set you up at the starting line. And I thought that was perfect, because medications did not fix me, nor will they ever. However, I do feel better equipped to handle my depression. And the question that I started asking myself wasn't, will I lose myself if I take medications? But it was, will I lose my life if I don't? Another question I hear a lot is, will medications even work, right? What's the point of trying? I will tell you, mental health medications are very individualized. Okay, so just because it works for one person, or they have, oops, my light went out, hold on. Okay, sorry. So just because medications work for one person, it doesn't necessarily mean that they'll work for another, or vice versa. If someone has no response or a negative response, it doesn't mean that the next person will. It can take months to figure out the right medication, or even the right combination of medications. For me, it took a long time. And it's also not uncommon for patients to have success on a certain antidepressant, and then all of a sudden seem to lose that benefit. So they're still taking it every day, they're still at the same dose, but for whatever reason, this seems to not help as much anymore. And that can happen in up to about 30% of patients with depression, which is extremely frustrating. Okay, I know that firsthand. Now, with this being said, it doesn't necessarily mean everyone will have to try 10 medications like I did. Okay, that was my journey. And it is more common with treatment-resistant depression. But I do think it's very realistic to expect some trial and error when starting medications, or when you're educating others about starting medication. The last point I want to hit on is, will they last long term? Okay, so say you find a medication that's working for you. Will it work for the rest of your life, or the rest of the time, that you're battling depression? To be completely honest, I recently needed to change my medication regimen earlier this year. And prior to that, I had been on the same regimen. I was on the same combination of 3 drugs for 2 years. And that was the longest period I had been on without touching it, same doses, same drugs. So for me, it was very frustrating. It felt like a setback that happened earlier this year. But you know what? Life happens. Changes happen. My body got used to it. It just wasn't working anymore. It didn't matter that I have coping skills. It didn't matter that I go to therapy, or that I have family supports, okay? Because that's depression. That's the illness. I'm on a sort of finely tuned combination of medications that needed to be tuned again, okay? And I don't run to my psychiatrist to change medications every time I have a bad day. And that's not the point I want to make. But I do look for patterns in my mood, okay? So when I feel myself flipping, or I start to feel more negative thoughts creeping in, I try to think, okay, is this burnout? Do I need to take a break from work or whatever other stress? Is this due to stress of relationships or some other situational stress I'm dealing with? Or is there no tangible reason? because sometimes that happens. And now I do feel like I'm in a better place moving forward to take the right steps to manage when there is no tangible reason than I was 8-10 years ago, in college. I'm aware that medications may not be for everyone, and everyone's healing process may look a little different. This is just a glimpse into my personal journey, and I hope it will shed some light on questions and conversations surrounding medications. Quickly, I just wanted to give you 2 websites that have some really good information on specific medications. So one being NAMI, National Alliance on Mental Illness. If you search in their resources, they have some good links. And then also the NIMH, the National Institute of Mental Health as well. So I know that depression will be a lifelong battle for me. But I do like to think that it will not play such a prominent role in my life moving forward, okay, that I have a better idea of how to navigate it now. I wanted to end with an anonymous quote that I really love, and I think it's really important for people with depression to keep this quote in mind. I have depression, but I prefer to say I battled depression instead of I suffer with it, because depression hits, but I hit back. Thank you. And I'll pass it on to Amy Eli next.
Thank you. So thumbs up if you can hear me. Okay, cool. Yeah, so I'm Amy or Eli or Amy Eli, all of the above. I will respond to any of those. I am going to try to share my screen here real quick. All right, so I'm just going to talk a little bit about art therapy and therapeutic art. I'm an art therapist at the University of Kansas Health System Marillac campus. So art therapy is a growing profession, so there's a lot of misconceptions about art therapy. And I'm guessing when I said art therapy and therapeutic art, a lot of people might think that those 2 terms are kind of interchangeable, but they're really not. I do have this kind of Venn diagram here to kind of show you the difference and where they overlap. But art therapy is a master's level mental health profession, and we work with clients just like therapists, but we essentially just use art and art making as our tools in the therapeutic process. So we are trained as both artists and therapists. And so in art therapy, art making is used as a means of communication, means of self-expression, and a means of containment as well. So there's definitely some overlap between art therapy and therapeutic art. But I just wanted to make it super clear that even though I'm showing you some art techniques that can be pretty therapeutic for people, that you're not really practicing art therapy. So I'm sure a lot of you know to work within the scope of your practice, so I don't have to say too much on that. But that's part of my job as an art therapist, is to make things clear. So yeah, so I did want to quickly share some art therapy resources because there are some art therapists in the Kansas City area that may be taking clients right now. So you can look at kansasarttherapy.org or missouriarttherapy.org. Those are going to be your best bet depending on the state that you live in. On their website, they do have just a list of art therapists that you can contact. They have contact information, websites, things like that. And I also added in American Art Therapy Association. There is an art therapist finder on there as well, where you can kind of search by zip code. But there's quite a few more listed on the state chapters. So I would recommend checking those out first. If you are interested in art therapy services, either for yourself or for a client or patient. And just a real tiny quick plug, I do have a book coming out in exactly a week. It is called A Graphic Guide to Art Therapy. And so if you're interested in learning a little bit more about art therapy, because it's hard to say it all in like a 15-minute presentation. So if you're interested in learning a little bit more, this is a really accessible way to learn. It's in the style of a graphic novel or kind of like a comic book. So it's illustrated, super accessible. So that comes out in a week. You can pre-order it on Amazon, and that is the last I will say about that. So my focus today, what I wanted to focus on is process art, which is exactly how it sounds. Instead of really focusing on the finished product, it's really more about placing the emphasis in the process of creating. So a little bit of background on that. In art therapy and therapeutic art, we kind of tend to think about art making in these kind of 3 different levels. And supposedly, you know, the most basic level is this kinesthetic sensory level. So that's where children are naturally creating. They're really more focused on the process than the finished product. They're not worried about the outcome. Even if you ask them what they've made or what they're making, they may not even have an idea. And as early as ages 8 to 10, that's when children start comparing themselves to others. They're trying to create realistic representations of the world around them, and they become really critical of their artwork. So this is when kids start getting really intimidated by creating art. And so just telling them to draw something is going to be kind of terrifying sometimes. I'm guessing since all of you in this conference are over 8 to 10, that maybe you haven't done a whole lot of creating in a while. And so my hope is to kind of promote art making for art making's sake. Yeah, so some of the benefits of this kinesthetic sensory process art, it can promote sensory grounding. You've got those sensory experiences, so it can help you get back in touch with your body. Mindfulness, Becca's been doing a great job promoting some mindfulness in here too, so we've kind of gotten an idea of what that's all about. Reducing overthinking, you're focused on, you know, learning a new technique. It's not so much about that finished product. Promoting openness to new experiences, practicing art making for relaxation or self-care, and hopefully, like I said, hopefully making art enjoyable again. So if you search on Pinterest, if you just look up process art, you're going to find a million billion different things. So I really wanted to narrow it down into techniques that are super easily accessible. They require few materials, and the materials that are required are things you might already have around your house or are very inexpensive and things you can find just about anywhere. Some techniques that most age groups and skill levels can execute, and ultimately some techniques that are essentially fail-safe. So what I mean by fail-safe is that as much as you can try to focus on that process of that technique, since y'all are over 8 to 10, you're still probably going to want something nice to look at when you're done with it. So all of these techniques usually produce a pretty nice piece of artwork to look at when you're done with it too. So here's the fun stuff. Collage is one of the least intimidating ways of creating. Doesn't require drawing or painting or sculpting, anything that would normally be kind of threatening or intimidating to people. And it's super accessible. You can use recycled materials, recycled magazines. You can use fabric or other items with textures to make it extra sensory oriented. So I do have a few videos to show you of these techniques just to kind of give you a better visual of all of these. Since I knew I was at 15 minutes to show you some techniques, tried to think of a way to do so. And since I work with teens and kids, I know all about TikTok now. So I made some TikTok videos. These are my first and only TikTok videos. So be gentle with me. So here's our first one. This is a torn paper collage technique. So this is really, I really like the torn paper collage because you've got those extra sensory benefits of hearing the paper tearing, and that can be really satisfying for a lot of people. I also like to add kind of some words or some phrases, some quotes that folks can pick out. Because I've had patients before that are like, oh, I really want to put this on my mirror when I get home. So I think it's a great place to put some positive affirmations, some nice quotes, some things that you're working on, things like that. So I also wanted to show you a few printing and marbling techniques. So this first one is a water and ink marbling. So I just kind of used what we had around the art room. So some washable ink. You can get ink specifically made for marbling that produces even better results. But if you just want to give this a try, this is a good place to start. All right, this next one is a Marillac favorite. This is a styrofoam printing technique. So we've got a bunch of these styrofoam trays, but you can use styrofoam plates. You can use Ziploc bags, anything with kind of that slick surface, because you're just using washable markers. So last one is a shaving cream marbling. So this one's got those extra sensory benefits of hearing the shaving cream coming out, the smell of the shaving cream, and just the movement involved with all of it. So I just used some ink that we have. You can use watercolor, you can use acrylic, but honestly, the most success I've had is with just food coloring. So if you have some food coloring laying around, that tends to work the best for me. So oh, and that one, yeah, you might get ink stains on your hands on that one. So if that's something that bothers you, keep that in mind. So the last few ideas that I had, I was just thinking of some ideas of ways that art can promote connection between other people or with other people. And, you know, in this pandemic world, we're really struggling with connection right now. So I was trying to think of some things that you could do either from a distance or still be able to keep that 6-foot safe distance. So I did find this website. It's called aggie.io. It is just a browser drawing and painting program, and it is hooked up through Wi-Fi, so you can draw with your friends in real time, essentially, wherever they're at. So this isn't just like drawing with random strangers. You log in, you get a link that you can share with your friends, and then you can all work on that same kind of digital canvas. So a very similar app that I found is called Canvas Draw Together. This is a phone app, and it's even more simple than the previous one, but so this one's hooked up through Bluetooth. So you're still going to have to be in fairly close proximity with each other, but you still can keep that 6-foot safe distance and kind of create on the same canvas. And since that's a mobile app, you're just kind of drawing with your finger. And it's a super, super simple interface. Last idea I wanted to share is nature art or eco art. This can be a great way to not only promote connection with others, but also connection with the environment. And this is really just big scale collage, finding things in your environment that look nice and arranging them in a way that's pleasing to you. So you can collaborate with other people and connect with others that way, or work on it individually and just connect more with your environment. So just a few ideas to share. And yeah, that's all for me. I don't have a really good closing statement. So thanks y'all for putting up with me, I suppose.
I don't know that you need a closing statement, Amy, Eli. I think your TikToks were the mic drop today. I've seen some folks in the chat asking what your TikTok is. Is that the right way to even say that? I have 4 teenagers. I should know these things, but I do not. Whatever you need to do to guide people toward the TikToks you create, please put that in the chat if you don't mind.
Okay. You know,
Right.
I had them on private mode, but I will tell you, I'll put my TikTok username in there, and then I will make them not private anymore.
Celebrity status is upon you. Those are really cool. The shaving cream one, that's neat. And I hadn't thought about the sensory benefits of all of that. So I'm really thrilled that the Marillac kids have you to guide them and help them out with some of those projects and things. Well done. Well done. Let's see, how are we on? We are great on time, actually. So we've got our roundtable folks here. Questions. You know, what questions do you have? I'm looking back through the chat. Let's see. I am curious, since you do direct interaction, Amy, Eli, with patients, how has the pandemic derailed you at all, or have you been able to adapt with distancing and masking? How's that affected your work?
It was a little bit of a struggle initially because we are doing masking and trying to get as much distance between the kiddos as possible. Which, like, I do art therapy groups primarily, so a lot of times when you're in a group and you're working all at the same table, that kind of helps motivate people. So when they're all separated and kind of working on their little clipboards like this, it does make it a little bit trickier to make it more of like a group process, I suppose. So that's one change that I can think of for sure.
Yeah, absolutely. That group time is valuable too. I'm glad you've been able to adapt and overcome some of those challenges. Cecil, I would love to know from your perspective, what is the one most important takeaway you want all of us to walk away with today?
I think the biggest takeaway that I would want anyone to walk away from is those two last things when it comes to when addressing Black youth. Just seek to understand or seeking to be understood. That's paramount. And then just listen and just believe them. Believe what they're saying. Validate their truth. I think that a lot of times, even in what I've seen happen with most white practitioners, is the nice approach, and I would coin it as a Midwest nice approach, and that is the equivalent of someone walking into someone's house, approaching a dog as if not to bite them, and Black youth often perceive it as such. So when someone is very nice to them, they're assuming that you're asking me not to bite you, which kind of puts them in the pretense that you're not there to help in any way. You're there to more or less to pacify that person. And so these different perspectives and having that cultural humility and that cultural awareness is very, very important, but it stems from, if I was to remove the aspect of culture, race, or anything else, just approaching every client seeking to understand or seeking them to be understood.
Very, very helpful. Thank you so much for your perspective on things. And again, I don't want to dominate all these questions, my friends, and so please feel free to throw some of your thoughts into the chat. I am interested, Liz, you shared a really, not a personal story, but many personal stories and experiences. And so same question that I had presented to Cecil, what's the one thing you want us all to walk away with today, the most important thing?
I would probably say the most important thing would be to know it's okay to take medications. I know someone had mentioned earlier today that, in the last 10 years, the discussion around mental health has improved. However, there's still a long way to go. And I think even more way to go as far as discussing medications and the stigma around medications. So I think that would kind of be the biggest takeaway. It's okay to ask for help. It's okay to consider taking medications, and more people are on them than you think.
Absolutely. Absolutely. One of the common themes that I've heard pulled through today is stigma, and how can we reduce the stigma of, anything pertaining to mental health, medication, suicide, talking about it, getting it out in the open. And certainly, Liz, I agree. I think medications are far more prevalent than anybody thinks, and good for folks who know they need the help and take advantage of that. Excellent. Okay. We may have, I have kind of lost track of where we are with time. Yeah, we've got more time for questions. We've got about 10 more minutes. So I think there's some in the chat. Hang on. Let me pull down. Okay. Great question, Becca. Thank you. Can we hear more about what the Kansas City Black Mental Health Initiative does in the community? And are there triggers that we should be aware of when we should refer patients or clients?
Two very good questions. It's going to save me a lot of typing because I was trying to type all that. So currently the initiative is developing the therapy project, which is 15 participants for 9 weeks getting free therapy from Black therapists. We're a grassroots organization, and we operate through Uzazi Village, which is kind of holding our foundation until we receive 501c3 status. So one of the other things that we've been doing is the church project. Another clinician for her home church worked with her church on creating a mental health. So we went into the church and provided a church month every Wednesday, providing information relating to those who go to church, religion, and making those connections between depression, grief and loss, anxiety, suicidality. And so that just actually wrapped up this last month. So we're looking to kind of look to duplicate that in other Black churches in the community. We have the Talk Shop project, where we are currently in conversations with several Black businesses and barbershops, as well as salons, in regards to being able to, on some of their busy days, or rather some of being able to kind of switch time frame where a Black clinician can go in and just talk shop for an hour. The biggest thing that we want to emphasize is community awareness. We want to destigmatize, and we want to make the community aware that these resources are available for people who look like them. Right now, the best way of kind of supporting that is being able to support we ask for donations to more or less develop these programs, or these projects. But essentially, what we're gearing towards doing is also research. We want to put a Black lens on the majority of the mental health research that's even done in the metro area, with the demographics that are present. I say all this to say the best way right now I could even ask for anyone to support is by donations, supporting, and sending Black clinicians our way, whether they're in private practice or working for an organization. Yes, one of the groups, a friend of mine, Meg, and Brittany, who's also a play therapist, also collecting a catalog of Black and Brown therapists, so much to the psychology today, but more in depth for what someone is looking for when it comes to gender or for representation. The second part of the question, I want to take all these 10 minutes, is what are some triggers to look for when approaching or to watch for? I think the most important thing is you're checking your bias, even in the aspect of crisis prevention. First step in addressing any crisis is self-awareness. So being aware of where you are and how you are approaching those situations. And the reason why I say that is because how you approach that situation, based on not just checking your bias, but checking your value system. Because your value system may be fairly different from the child that you're approaching. It is just important I'm sorry, when I hear triggers, I hear problems, and the only thing I can think of is solutions for them. So when I think of like the solutions, make sure you're using your open-ended questions, make sure you're using affirmations, making sure that you're using coming from a place of empathy. And the strongest thing I can do to tell you is to use reflective listening. Reflective listening will get you far with Black youth, with the Black population, and addressing yourself. You just want to make sure.
Perfect. Thank you. Really appreciate that insight for sure. Liz, I think we had a couple of questions that had popped up for you, and I'm going to lump a couple of these together. Part one, many parents seem reticent to medications for their children or teenagers. Are there resources you would recommend for them? And also, do you recommend, from a storage perspective, parents keep the medication locked up for their kiddos and provide it one day at a time? Or is that dependent on the child and age?
Okay. Well, for the first question, I would definitely say the two websites I mentioned before are helpful. So NAMI and then NIMH can have some good information, but I would also say the Society for Adolescent Health, it's the SAHM, the Society for Adolescent Health. That website also has a good mental health resource page or link that I know has some good information for parents specifically. And then for the other question, I would say it can, I think, depend on the child, but on the other hand, I think you can never be too safe as far as, you know, having the parent keep the medication or give it to the child one day at a time. And then that way the parent can also make sure the child remembers to take it every day, or just another way to check that they are getting the medication, because unfortunately a lot of times in the moment you may not see signs, but then looking back you can see, you know, maybe signs that the child was struggling more and you don't want them to have that access to a good amount of medication. So I think you can never be too safe with that. So yeah, I think overall I would recommend having the parent keep the medication or just be very involved in the child taking it, not just giving it to the child, you know, as soon as you pick it up from the pharmacy, and then that's the last you see of it.
Perfect. Thank you. We appreciate your perspective on that and your expertise, definitely. Amy, Eli, do you ever use the art therapy techniques one-on-one with patients in order to help them express their feelings, or is it typically in a group setting?
There are very few occasions where I've worked with individuals, just because as our schedule is where it's at Marillac, we just are group therapists. So typically just groups, but every now and then there's an individual that I see. So
okay, thank you. Another question for Liz. What are your thoughts on TCS? And then it says, I think that's right, for treatment-resistant depression.
Okay, so I'm thinking they mean TCS is transcranial magnetic stimulation. So it's a non-invasive procedure, but they use magnets essentially like on the head to target certain nerve cells. And it has been shown to be beneficial in treatment-resistant depression. So I think it's a good option. That it will very much depend on the patient, because if you have a patient who doesn't really want to take medications, chances are they're not going to be very open to having magnets stuck to their head. So you can imagine there's also a stigma towards that. And even similar ECT, if you've heard of electroconvulsive therapy, is also similar as far as it being a non-invasive procedure that also has very good evidence for treatment-resistant depression. So I think for both of those, the biggest thing is getting over the stigma of that, and like a lot of patient education that it can be helpful. So I definitely think it is an option, a good option probably for some patients. May even be better than going through, 10, 12, 15 different combinations. And I think also some physicians are probably more comfortable using it. So, either referring patients to an ECT treatment center. But so I think it will also depend on the physician. But I mean, there is strong evidence to support it. So I think it just kind of depends on each patient.
And I learned yet another new thing today. I did not realize that was an existing treatment option, so thank you for the clarification on that. Cecil, I think we've got time for one final question, and it is, are there any barriers to receiving help and support your client base faces that tend to go unspoken or unseen?
Can you repeat that question just a little bit?
I can. And let's see, Becca, you might need to clarify. Are there any barriers to receiving help and support your client base faces? I apologize. I said alarms, yeah, that tend to go unspoken or unseen.
Yes, I'm sorry. There's construction. It's all on me.
Thank you.
So I think the majority of the barriers is just a lack of resources. I mean, yes. The biggest barrier is the lack of resources or accessibility to those resources. Even in the aspect of what I mean by resources, like Marillac provides acute psychiatric hospitalization. In the aspect of someone who's to see just a therapist regularly, usually they would have to look for private practice. There's only so many private practice practitioners in the community. Then you go to the catchment area, location for Truman, and nothing against anyone who is here, Children's Mercy, or anyone else who provides community services, but there's often a high turnover. There's also a lack of diversity in those fields. There's a lack of inclusion. So when I talk about like lack of access to resources, I also mean in the aspect of people who look like you, who's providing it, who are able to be there throughout your treatment, rather than someone who's there to be postponed to that. And then when you talk about private practices, you're not just talking about insurance or if someone takes Medicaid, you're also talking about the price of therapy itself, where on average, we're looking at anywhere from $90 to $110 to $125. For someone who is needing weekly therapy, even bi-weekly therapy, average, just not there. So those are the hugest barriers outside of the stigmatization and cultural paradigms around mental health or history around health in general in Black folks. Sorry, that are barriers. Current barriers, past barriers, all placate into all the barriers.
Perfect answer to a strong question, and we love your honesty and your transparency as you talk to us, so thank you for that. We are now at 3:21, and we're going to wrap up our day starting at 3:30 with Give Me 20, and I'll shift over moderator responsibilities to my friend and colleague Emily Snow. But please go take some moments for yourself, reflect, nourish, do what you need to do, and we'll see you back here at 3:30. Liz, Cecil, and Amy Eli, thank you for everything you brought to our table today.
Thanks for having us.
Absolutely. What a pleasure.